and Marketing, IIHMR Bangalore, and I will be your host for today's webinar. In 2024, World Health Day continues to highlight the need for global collaboration and action to address pressing health challenges. With the focus on innovation and resilience, this year's observance underscores the importance of adapting to evolving healthcare threats and advancing equitable access to healthcare for all. Through initiatives, discussions, and partnerships, World Health Day 2024 aims to empower individuals and communities to prioritize their health and contribute to building a healthier world. Welcome, participants. We are thrilled to have you all to join us today for the webinar organized by IIHMR Bangalore. IIHMR Bangalore started in the year 1984 at Jaipur as a society and in Bangalore since 2004. The four key verticals that we are into are academics, research and publications, trainings and consultation. Into academics, we offer postgraduate in hospital and health management. It is a 2 years full-time program with specializations in hospital management, health information technology management, and pharmaceutical management. Seats approved are 120 with excellent placement record. Coming to research and publications, the types of projects we deal are evaluation, formative, implementation research, and social assessments. Our thrust areas are RMN-CH, life course health, NCD, health communication, and digital health. We cover urban, rural, and tribal geographies. The third key vertical is trainings, learning and training department. So we are into MDPs, FDPs, and EDPs. We run certification programs, student engagement programs, webinar series, and we also have equipped for in-person, virtual, and hybrid mode programs. Moving ahead to consultancy, we have our faculty and institutional we are into faculty and institutional consultancy, and the thrust areas we are into NABH, quality management, growth and strategy, and project impact management. Moving forward, for today, here we have the expert panel to enlighten us about health as our right. So the first panelist we have Dr. Mayur Kaku. He is the consultant and the neurosurgeon at HCG, and at PS Medical College. He also works as senior consultant neurosurgery and the head of department for yoga and neuroscience. We have Dr. Neema Bhatt. She is the senior consultant hematology and pediatric oncology at Apollo Hospitals. We have Dr. Pushkar Desai from Sultan Qaboos University and Hospital, Oman, a senior specialist anesthesiologist. We have Dr. Vikrant Pawar from Sir H.N. Reliance Hospital, Mumbai, consultant critical care. We also have Dr. Chetna Mam. She is the adjunct faculty at IIHMR Bangalore, and she also mainly focuses on management consultants, healthcare quality audits, and medico-legal practice. I welcome the panelists. Welcome you all.
Thank you. Thank you, Joyce.
Thank you very much.
Yeah, welcome, sir. Thank you. So today's session, to moderate today's session, we have Dr. Deepashri Ma'am. She is the assistant professor here at IIHMR Bangalore. Ma'am, over to you. And we are looking forward for the interesting panel discussion. Meanwhile, dear participants, if you have any questions, you may kindly post them in the chat box. During Q&A session, they will be addressed. Over to you, ma'am.
Thank you, Joyce. Thank you so much, and welcoming all the participants on the Sunday, and happy World Health Day to you all. We celebrate our annually the April 7th has annual health day or a world health day, which raises global awareness about particular health issues and promotes health well-being to all. We all a little background about the World Health Day. It was established in 1948 by the WHO. This observes by emphasis the need to tackle urgent health concerns and advocate for policy changes to enhance health and outcomes. The year 2024 marks our 76th anniversary of WHO. As a part of celebration, WHO has chosen My Health, My Right as a theme of World Health Day 2024, which focus on the fundamental rights of access to quality healthcare, education, as well as information. So to begin with, we have Dr. Chetana. Welcome you, ma'am. And the first question goes to you, ma'am. We know that India has given a health right in our Article 27, which guarantees that fundamental right to life as well as personal liberty and the right to health. So has health is a state subject. Even the director principles of state policy, the Article 38, 49, 42, 43 says about the obligations about the health rights. Ma'am, to understand in a more detail and a brief way to all the common people and the doctors ourselves, we wanted to know much about what is health right, ma'am.
Good morning to one and all. At the outset, I would like to thank IIHMR, the Dr. Deepa, for giving me the opportunity to be a part of this panel. Like you rightly pointed out, the World Health Organization, on the occasion of the World Health Day, has sort of, they titled as My Health, My Right. Now, the question here is, when we say a right to health, everyone should have access to health services when they need, where they need, right? And at a cost which will not, give them either free, if that works, or that's something which does not involve any financial hardships, right? So no one should get sick, because they are poor, or once they become sick, they should sort of, not lead to an unhealthy life for lack of medical facilities and various aspects. Now, again, as health has been defined, it's not just physical health. It also comprises of the physical, mental, social, psychological health. Now, with this concept, in understanding the right to health, a common question which comes to any commoner is there a statutory framework in our country, in the Constitution, that health is my fundamental right? Is there a statutory framework? What does the Constitution of India say about my right to health? These are the common questions that are posed. Well, though the right to health is not explicitly provided in the Constitution of India as a guaranteed right to health, it may not be written, but it is definitely implied as a fundamental right by ways of the Article 21, which you mentioned, and various directive principles of state policy and also the constitutional provisions. Now, right to life. So what is article? Let us try to understand. It clearly says no person shall be deprived of his life or personal liberty except according to procedure established by law. Now, it again defines that it is not this, fundamental right. Article 21 is considered as an, umbrella right because it encompasses so many inherent rights within. Now, this right to life, or the personal liberty is sort of, it includes, right, when we say right to life, it includes right to sound health. Now, how have we been enforcing these rights? There have been various case laws, various case precedents, which have brought out time and again that right to health is inherent to right to life. And therefore, one's right to health is no longer a privilege. It is our fundamental right. So if you go back to history, whether it is the Paschim Banga Mazdoor Society, or it is the Parmanand Katara versus Union of India, there have been various judgments which clearly says that right to health is part of right to life, which is the coming under Article 21. And it includes not just related to health and sickness, it also includes right to life with human dignity, also for free, pollution-free environment, and mental health. So all of these aspects have been included in various case judgments. Now, coming to the directive principles of state policy, which you mentioned, these are again they come under the part 4 of the Constitution of India, which gives specific directions, positive directions to the state. When we say the state, the country, the respective states, an obligation is put to the state to take positive actions to promote the welfare of people, whether it is social, economical, and various other democratic aspects. Now, what do these specifically the DPSP says? You mentioned a few. Let me read out certain articles under the directive principles of state policy. Article 38 lays down responsibility of the state to establish a social order for the promotion of welfare of public health. Now, Article 39E pertains to protecting the health of workers. That is why you see there is a lot of health-related, privileges, facilities, amenities, which come under the various labor statutes, because the health, is very, very important. And Article 41 deals with assistance in special situations, whether it is sickness, disability, old age, and things like that. Article 22 is another directive principles of state policy which deals with maternity benefit, which is focusing on maternal health and the health of infants. And also, if you see that we all know there is a Maternity Benefit Act 1961, which has seen several amendments and iterations. Article 47, it gives the primary duty of the state to improve the public health. And that's why you see a lot of public health activities in the governments which are happening, be it with the IIHMR Bharat or the Universal Immunization Program, the pulse polio eradication, improving the nutritional status. So likewise, there are so many, programs and successful programs in public health, which India has demonstrated. Now, Article 48A is again, which came later when one of the amendments, that the duty of the state to provide good and healthy pollution-free environment, because environment and the quality of environment, a pollution-free environment has a bearing on one's health, and which is essential for right to life and personal dignity. So as you rightly pointed out, yes, definitely health is my right, not just a privilege. But I mean, how am I is my right being fulfilled? Is my right being honored? That's another question to answer, because it depends on the availability of healthcare facilities. If they are available, are they accessible to me when I need it as a common person? And if it is accessible, can I afford it? These are three large questions which come time and again. The government machinery is working towards addressing these needs. But yes, all of this are important for us to understand that if I land in a situation where there is no availability, I'm deprived of my availability to health resources, I'm deprived of my access to healthcare services, or is cost becoming a challenge, financial hardship being a challenge to meet my healthcare needs, then definitely there is a mechanism in the judiciary by way of enforcement of my fundamental right and the DPSP to seek justice in courts of law. I think this is my submission here.
Thank you so much, ma'am. And like regarding the articles you have established and gives a right way of taking our rights, like talking about our health rights. And yes, rightly pointed out, how well we practice these rights depends upon both government as well as ourselves, how well we ask for our right. Yeah? Hold on this thought, ma'am. I'll come back to you again. Moving to Dr. Mayur. Dr. Mayur, health rights is not only getting the access, but also getting a right set of informations to us while taking a treatment or getting a procedure done. So when it jot down to an hospital sector or an healthcare sector, we do generally talk about health education as well as an informed consent during any procedures. So what do you think? How is the informed consent practices in, especially because you're a surgeon, so I'd like to ask how it is well practiced in India. Do you
Good
think
morning. Good morning, Deepa. Yeah, please,
yes,
you finish
and
off your question. Finish off
yes,
your question.
and do you think, sir, how well we does this consent is only just on the papers, or are we rightly educating patients about the procedures? And
Okay.
do you think these kind of education help people to make a decision, sir? Over to
Okay.
you.
So the thing is that question was very long, but
Yeah.
means what I can do here is I can pick up one point from you, that is the patient being informed correctly. That
Yes.
is what you want to know, right?
Yes, sir.
Like in short.
In
So
short, yes. And
yeah.
well, this helps
Uh-huh.
them for the decision making, because health, I have to make a decision
Okay.
for my life. So whether these kinds of consent help in taking such decisions.
Okay. So I would request you to please allow me to share one slide
Yes,
so
sir,
that
sure.
everybody can understand what is happening on the ground, and how we can improve it. I'm not trying to malign my own field here, but at the same time we should know the ground reality here. Okay, so that
Yes,
is
sir.
why I would like to share one slide and I would like to show you. Are you able to see here?
Yes, sir. Yes, sir.
Yeah. Yeah. So just I would like to read here, then you can see what is exactly happening. I like this is by Anuradha, and I was hospitalized to a reputed hospital. I have covered the name of
Must,
the
yeah.
road because it may highlight some hospitals. For my cervical slip disc pain, due to which I was not able to sit for 5 seconds also. Doctors said it's a must that I have to undergo surgery. Before I say yes, they conducted all blood tests and gave package details in which included cost obviously in lakhs. Somehow escaped from there in spite of three doctors tried to brainwash by saying my shoulders might get paralyzed. While going back home itself, my brain might get some attack. I'm sure more than 50% of people get scared and get surgery done in that situation. I was having so much pain. After that, I checked with two more doctors of reputed hospitals. Everyone said it's a must that I have to undergo surgery, else I may be in danger. That's when I visited Dr. Mayur Kaku. He saw my reports and said surgery was not required. I cannot express how much me and my husband were relieved. Doctor literally felt confidence in me that it can be cured by regularly practicing yoga. He spent his personal time, that is Sundays, to teach me yoga. He had to put extra efforts to make me learn yoga as I never did it before. My family had decided that I will not go to work again. It's been 1.5 years now that I am surviving with no treatment, no medicine, but yoga. I am doing minimum 7 hours of my office work, of course, from home due to COVID, along with cooking. And rest is my, they have shared their gratitude towards me. So with this, if you see, one more I will share. Ravindra Kumar, you can see here, he was diagnosed in early 2020. Similarly, he was also asked to undergo a surgery costing around 3 lakhs. Then I examined him, I gave him confidence. Actually, he was already admitted, he was put on the OT list, and from there he took discharge against medical advice. And then he came to me. And then you see that I advised yoga, Katibasti, and all the treatments. And then he had full recovery in 3 months. He is 60 years. The previous patient was around 50 years. And now it has been 3 years. You can see he is doing 108 Surya Namaskaras on Ratha Saptami. He is 60 years, 60 plus now. He is 63 now. So you can see here he is telling that right solution for the people who approach with problems. One more I will share. This is for with one young lady, 33-year-old. Same that she was also advised to undergo surgery, and then we had advised her yoga, and through that. Now, for your kind information, I am a neurosurgeon. So if people may start thinking that Dr. Mayur is a yoga therapist or something like that, but no, I am a neurosurgeon, and I am in practice since last 8 years. Along with being a neurosurgeon, I am a childhood yoga practitioner as well. Now, question comes here is informed consent. At the same time, what is the best solution for the patient? with our medical degree, yes, definitely surgery or medical management is best treatment available. But with overall holistic approach or overall 360-degree understanding, you can see that patients improve even without surgery, without medications. And as a doctor, my role should be to give the right solution to the patient. Informed consent, as you saw, that in one of the reviews, the patient mentioned that, they were frightened. So fear is one factor which plays a role in convincing people to either go for surgery or not go for surgery, or go for treatment or not go for treatment. Now here one whole thing is like, basically, if I want to say that, some things are driven financially. And if these things are driven financially and we as doctors, we are utilizing our medical knowledge to frighten people to undergo surgery, that is not correct. And it is not only happening in India, the fear driven things are happening all across the planet. And somewhere, pandemic situation also, when we were in pandemic situation, we have seen how fear has driven purchase of medicines and holding of medicines, and the views about vaccination and so on and so forth. So informed consent is a very complicated subject. At the same time, with the knowledge, with the medical knowledge available, there is a chance that, patient right may be overridden, and we may use our medical knowledge to convince them for the surgery which or treatment which may or may not be needed. So this is a very interesting ethical question. And somewhere as a medical community, we have to introspect whether we want to drive ourselves in terms of healing people or helping people in the right manner, or just chasing the numbers. So I hope I may have crossed line, and I may have brushed some shoulders here. But yeah, I am ready to face, and I am keeping on facing this. I am ready to face it, not an issue. I hope I answered your question, Deepa.
Yes, Dr. Mayur. Dr. Mayur, is that a compulsion? So there is two questions about informed consent also. Whether informed consent is just, and patient education or informed consent is just a procedural requirement, or whether it's a legal requirement. I think Dr. Chaitanya, you can also add your points in this. Whether you think an informed consent is just for a legal requirement or it should be a procedural issues.
It is both procedural as well as a legal requirement. And third, I think there should be an ethical, coating over it, that, whether informed consent has been taken in an ethical manner, information has been provided at a, complete holistic manner or not. That is what we have to understand.
Okay. Yeah. Dr. Chaitanya, your viewpoint.
Yes, certainly I concur to Dr. Mayur's views. It is an ethical, a legal, a medical requirement altogether. Now, coming to the legal point of view, as we all know, when the healthcare came under the ambit of the Consumer Protection Act, the relationship between a doctor and a patient has shifted to one of a contract for service, just like any other contract that we get into, a business contract, an employment contract, and things like that. Courts have been looking at it like any other formal agreement. And so that, therefore, if that being the case, then which is the document, which is the agreement copy, then it is the consent form, because that's the only document in the medical record where both parties agree upon certain terms and conditions, agree upon a medical line of management, or a surgical line of management, knowing its risks and benefits. And also there is an endorsement by way of a witness who is also according his presence that this discussion and decision, shared decision making happen. Now, what is consent? Consent means simply consensus of two minds, right? So which means both the doctor as a provider and the patient as a receiver should agree upon in the same way, right? Now, coming to patient as a right. Now, we spoke about human rights. Right to information, right to life, right to bodily integrity, right to privacy, right to confidentiality. These are all fundamental rights. So likewise, when it comes to the, informed consent in health, what we should understand is that patient has a right to understand what's going wrong with him or her, trying to know the diagnosis, what's the line of management, are there multiple modalities of treatment, is one better than the other, which is more riskier, and what happens if I don't undergo the treatment? And then the patient, it takes a decision for himself or herself, right? So that's where it stands, including the right to refusal, because it deals with, one's own body and, so that, autonomy over one's own health and body. So all of that. So it is therefore the primary duty of the provider, be it the doctor or the healthcare systems, to consider the patient as a partner in his or her own care. Gone are the days when we had those paternalistic approach where, it more or less it was a monologue. The doctor would decide so many things for the patient. But today we have to embrace that, this is a basic human right for a patient, access to information, education, make them understand in the language that they know, and then obtain a free will, like doctor mentioned, without any fear, without any force, without any undue influence, no coercion, including the choice to refuse or choose the second best modality. As a doctor, I may say the first choice is this is the second choice, but the patient may choose the conservative management. We should still respect that right, and that's where the informed consent plays a very important role. It is a legal, ethical, moral, medical, all sort of right, which we should understand and respect. And of course, it's a part of the Charter of Human Rights, which comes from the Human Rights Commission as well.
Yeah.
Not doing anything without a consent amounts to negligence, even though if it has been done in good faith, although there has been no harm or injury. There could be, there are various decisions, as doctors and professionals, we know, be it the Samira Kohli versus Prabha Manchanda or the Prashant Dhananka case of neurosurgery. There have been enough decisions where courts have taken a very stern view when we have not followed our duty as healthcare providers to take the due informed consent and recorded it, also from the documentation perspective.
Thank you, Dr. Chetana and Dr. Mayur. Welcome, Dr. Nima. Next, the question would be for you, where you are yourself as a pediatric oncologist, and we are talking about the age group where consent cannot be given. They cannot make their own decisions, right? And you work with this set of group. Ma'am, where does this concept of assent has come in place, has a right, and how well it is practiced? I want your experience on this, ma'am.
That's a great question, Dr. Deepa. So, great question, but also a very gray area is what I would say. So I was trained in the US. Before that, I finished my MBBS in India and then went to the US for my post-graduation and fellowship. So during my medical days in India, especially when we were posted in pediatrics or in the adolescent department, we used to see mostly, conversations and discussions happening between the doctors and the parents of patients. The children would be sort of in the corner. They would not really be, included in conversations. Of course, it's understandable when the children are really young, under the age of 6, 7, 8, 10 years old. But even teenagers, the age of 12, 13, 14, the parents would sort of take the prerogative upon themselves and make medical decisions for the child and communicate to the doctor. And it would just be taken as, as the child has also consented or assented or whatever. That concept was almost non-existent. From this, when I went on to train in the US, that was a vigorous part of my pediatrics training when I did my MD, that we always include children anywhere between the age of 7 or 8 until the age of, 17 years of age, that we have to include them in the medical discussions, that because it's pertaining to their health. Yes, their understanding may be limited. Yes, they may not really be able to give a complete informed consent in the informed consents sense of point, but it is important to include them in their care and in helping them make their own decisions regarding what they want and what they don't want. So from there, I went on to do my fellowship, which also included pediatric oncology and transplant. So these are all, as you had, as you mentioned, they're all very long periods of treatment and require multiple visits to the hospital, vigorous treatment, a lot of side effects that the child may have to face. So if I go by the international guidelines for ASCENT, it's actually between the age of 7 to 12 or 7 to 13. Children have to be included in the medical, decision making.
Discussion, yeah.
Correct, regarding their medical condition, and a verbal assent at least has to be taken. So it may be difficult to take a documented assent or a signature from the child for every treatment between this age group, 7 to 12, but at least a verbal assent, as in breaking down the condition to a level where the child can understand what you're going through. And this is potentially what you're looking at, at least in the way that they can understand, and sort of involving them with the discussion. Otherwise, these children are in the process of, mental growth and development, and they may not really be able to verbalize all of their concerns. But the moment you include them in their conversations, we see that a lot of these kids actually have questions. So to give an example, I have a 10-year-old who I'm treating for leukemia. So it's called acute lymphoblastic leukemia. Very smart child. He was going to school when he was diagnosed, and we had to put a chemo port for him. So chemo port is nothing but a big, central line that goes in the chest and goes to a big vein through which we give chemotherapy. And I was talking to the parents, but made sure that the child was sitting in the room with me. Of course, took the parents' permission to, let them know that the child is going to be there during the discussion, because he's a 10-year-old. He can understand a lot of conversations that happen. And as he was talking about it, I think it helped actually having the conversation in front of the child, because his first question was, I play football. You're talking about something that, you're doing a surgery and putting in me. So do you think I can still play football? So immediately, I think it was very vital that he was able to be there and hear that conversation. So I was able to answer his question and say, yes, you definitely be able to continue to play football. Can I go to school? So after about 5 minutes of conversation, I was talking more to the child than the parents. And he felt very happy at the end of the conversation, saying, doctor, even though this is sort of a life-threatening condition, leukemia is a life-threatening condition if it's not treated, at the right time in the right way. You made sure to involve me in your conversations, and we've had a great rapport since then. So I think ASCENT, even in the younger age group, not just as we were just, the preceding conversations as in part of ethical or medical or legal requirement, it also improves the rapport between a patient and the doctor, especially when they're children going through life-threatening conditions. It's very important to have a good rapport with them. Otherwise, they don't share most of their insecurities, their doubts, their anxiety, their fear, nothing comes out. So I think this gives a great platform to start off. Now, coming to the older age group. So when we talk about children between the age of 12 to 13 to about 17, 18 years, of course, 18 is the age where you can take informed consent. That is the legal cutoff of age. But between those two ages, between 13 to 18, they're in a very tumultuous mental stage where they are sort of starting to identify themselves as a young adult, but they're still not able to, they've not completely gotten over their childhood insecurities. So these children sometimes take more than one conversation to open up. They take more than 1 or 2 sessions to actually start asking questions. And for us as medical providers, especially as pediatric oncologists or transplanters, it poses a huge challenge, because we're looking at something that's life-threatening and we have to start treatment, say, within the next 1 or 2 days. But at the same time, do I completely want to leave the child out of the conversation? Do I just want to involve the parents and say, this is what is good for your child, let's just proceed? But I feel in that way, we're not going to be doing justice to the child or to the patient. So I always make it a point to go and visit such patients at least 2-3 times a day. Sometimes even try to catch this adolescent or teenager at a point where their parents are not there, so I can sort of understand what is, because sometimes these children get very very insecure about asking questions in front of their parents. They are very unsure about how they should behave in front of their parents. But when they're approached by a completely non-judgmental third party, they come out and ask a lot of questions, which is very surprising. Especially the teenagers, they have very valid questions to ask, but very relevant to their treatment. So for these patients, an informed, proper assent as well as a written consent, yes, along with the parents' consent is extremely important. So according to some guidelines, they say even if the age group between 13 to 18, if these patients are able to give informed consent after understanding the whole thing, there is an option to even eliminate parental consent. But that's, of course, as I said, it's a very gray area. I tend to always still involve the parents as well, even in this age group, because even though they are almost adults, they're not adults yet, and they may not have full understanding of the world, what's going on, what's coming next, and all of that. So it's good to keep both parties in mind, but treat even the pediatric patient as an individual and give importance to their opinions and make sure that they're involved in the conversations. I think it's extremely important.
Thank you, Dr. Nima. I have one more question for you. Probably the second round I would like to take. Next, I would like to talk with Dr. Vikrant, and I'm moving to the next vulnerable area where the patient come with a critical condition. Dr. Vikrant?
Yes.
Yes, Dr. Vikrant, the next is the vulnerable. One is the pediatric, then will comes the critically ill who cannot make their own informed decisions. All right. We use the physical restraints and chemical restraints while treating in such physical conditions, where in the critical conditions. Are we actually taking a concern before this? Because any restraints, I would be stressed out physically as well as psychologically. If you are tying me to a chair and making me to sit there, I think I will be very much concerned. So how do you make people to understand this, sir?
So it's a great question actually, but it has a multifaceted, answers. It depends on the situation, Deepashri,
Yes, sir.
because we, in critical care, we look after patients who are, at the various spectrums of the disease. So sometimes the patient may be, conscious, but might be having, tube inside, like endotracheal tube, which we call a ventilator tube. Okay? So when the patient is in the process of, getting weaned off from the ventilator, you are supposed to stop the sedation, or what you can say as a chemical restraint, right?
Okay.
So you are supposed to stop the sedation and assess his neurological status, whether he or she can get off from the ventilator. So in that situation, it depends on the patient and the disease process and the psyche of the patient, how he or she is going to behave. So there might be one person or one patient who will be extremely calm in that situation, and understanding all the situation, he is cooperating and ready to get off from the ventilator so that we can remove that tube. Another patient, may be having some pain or some distress because of some tube somewhere else in the body, or some because of some disease process, might be having pain somewhere, or maybe in distress. Another patient, third patient, may not be in full senses. So he might be understanding some things that he might be hearing some voices and all, that people are around, but he may not be in full senses to understand what's going on. So he or she may behave in a very, very erratic way, that he may just pull up the legs and pull up the hands. He may just try to pull out all his lines, tubes and all. So it depends on in which situation the patient is, and in any situation, the ultimate goal of the doctor, the nursing team, the medical team is to keep the patient safe.
Yeah.
Right.
Yes,
So
sir.
that is the ultimate goal. So considering that, it depends on which category the patient is, at that point of time, and accordingly you will choose the modality of kind of restraint you are going to use. So definitely, we many a times we have to use restraint, but that is used with consent. The consent is taken from the nearest family member who is available there, because in most of these situations, the patient may not be in full senses or may not be in a situation to give consent.
Correct.
Right. So the immediate family member or the caretaker gives the consent. It has been explained to them, what the situation is, why we require restraint, because in if in such situation, if you do not restrain the patient either chemically, medically, or physically, there is a possibility that he may pull out the ventilator tube, he may pull out some central line or some hemodialysis catheter, he may pull out Foley's catheter, injuring himself. So the primary goal, to keep the patient calm, keep the patient restrained, is to keep him safe from self-inflicted trauma, right?
Okay.
Because as you said that it is ICU, a patient is critically ill.
Yeah.
By after so much of efforts and by God's grace, the patient has reached a particular level,
Yeah.
when he might be in a recovering stage. And if he pulls out some tube or some vital catheter or something, things may go wrong horribly, and we may go back to the same square position where we were a few days back, right?
Yeah.
So the ultimate goal is to keep the patient safe, and for that safety, these restraints and all are practiced. I agree with you that in some cases it may be a bit of distressing to the patient, but yes, safety of life comes first. These distressing features or the complaints or the symptoms, they can be taken care of by counseling the patient, psychological counseling, tender loving care, and sometimes some medications, which helps in reducing the anxiety, distress. So when we say sedation does not only mean that the patient is given a medicine to sleep. There are some medications which reduce your anxiety. There are some medications which are opioid like, or opioids. So these opioid medications, they not only keep you calm, but kind of give you a happy feeling that everything is fine, everything is okay. So it's a multifactorial cause where the patient requires restraint, and also multi-faceted treatment also, whether you have to restrain them physically only, or you have to use the medical means to treat that. But yes, I agree. Many a times it becomes distressing to the patient. Patient may be in a fear or anxiety that what's happening. But first, as I said, counseling the patient. Uh, for those who can understand or who are listening, they may not be able to, reply to you because of the tubes and all, or may not be in a position to speak and reply, but they may be understanding. So whether or not we are sure or not whether they are understanding, we should make an effort that to explain them that try to be calm.
Yeah.
And when the counseling or the verbal things are not working, then yes, you may have to use physical restraint. But at the same time, it is counseled to the family member that why it is required, and written informed consent is taken. I'm sure in most of the all those corporate hospitals it's there.
Thank you, Dr. Pawar. I think I have one more interesting question for you, but we'll wait for the second. Requesting our panel members to see the chat, because we are getting some interesting questions in the chat. And if you would like to answer in the message, you can, or if not, I will take up at the end of our discussion. Now, bringing a new perspective, I want Dr. Pushkar to answer what are the informed consent practices in the Oman UCs. Dr. Pushkar?
Hi. Good morning, Dr. Dipashri. First of all, I would
Yes,
like
sir.
to thank you and organizing committee and Dr. Mayur for introducing me to this wonderful platform. And yes, happy Ugadi to all in advance.
Oh, same to you,
Yeah.
sir.
Yeah. So we are ending our year on a very positive note, I guess, on this platform. And yes, coming back to your questions, even though I am working in Oman, I'm not working out of world or something. So here also the informed consent practices are like standard practices which are being followed everywhere in the world. However, informed consent, as the previous speaker said, it has to be voluntary. Okay, it has to be given by the patient when he is in his full senses. So he should be able to understand what procedure he is going to get into. So these two things should be mandatory when you talk about informed consent. Now, unfortunately, in this consumer-driven world, we have taken the medical practice into the consumption field or the service industry as a service industry. And that's how it has all become mess. Another thing I want to say here is consent, even though we talk it as rights or ethical issues, it denotes your society or your whole nation or the culture, how much evolved you are into. See, unlike back there, most of the cases, like I have worked in government hospitals in India as well. So consent is a mandatory, mandatory just to avoid the medical legal litigations, right? While in corporate also, the primary intent is to avoid the medical legal litigations. However, in Western world, the consent is taken keeping in mind that each and every life is important. Okay. So now what do I mean by that? See, our cultural practices and our dealing with the patient and the society is totally different from the Western world, where there everyone is treated equally. Okay, irrespective of the race, irrespective of the sex, irrespective of the social stature and the finances. However, at the same time, patient also understands that the healthcare providers, they are there to help, not to loot them. And this is quite, this is happening back there in India, that general population thinks that doctors or the healthcare providers are there to loot them. They do the unnecessary investigations, but they don't understand that if they don't do these in basic investigations, and if something goes wrong, the law has given them right to approach the court. Okay, and it becomes very distressing on the healthcare providers to prove them innocent, right? And there comes the part of informed consent. So in Oman, coming back to your question, each and every patient gets an informed consent, whether it's in the government hospital or the private hospital. The treating physicians, they will explain in normal layman terms to the patient what they are going to get the procedure. Now, one aspect of the consent is there should be a reasonable average patient standard, right? So the average patient should reasonably understand what the procedure or what investigation he is supposed to get into. Then, hello.
Yes, sir, you're audible, sir.
Pushkar, you are audible. Please
Hello.
continue.
Hello.
Sir, you're audible, sir. Please continue.
Hello.
Pushkar, we are able to hear you, Pushkar.
I think my voice is not coming.
We are able
You
to
are
hear
audible.
you, sir.
Okay, I just presume that my voice is coming. Okay, so what I was saying that informed consent practice in Oman is pretty much standardized, where each patient is being explained about the procedure. And fortunately or unfortunately, as an anesthesiologist or critical care providers, we come as a second line. And for us, the main question of the patient is to have a pain-free surgery and the pain-free post-operative recovery. So as our moral responsibility, we tend to give them all the available options with us in order to choose their plan of anesthesia, if there is any chance to choose between different types of anesthesia, because sometimes you have different kind of surgery where you have only one option of choosing anesthesia. However, there are multiple options of pain-free recovery in the post-operative period as well. So there, I think you tend to circulate the patient information booklets when we go and explain about the procedure and the post-operative recovery in these patients. Nowadays also what I have seen is people are moving into the video form of consent. So
Yes.
that's a more interesting thing, where instead of just explaining the terms in layman language, you show patients animated videos of what they are going to get into. So all the procedural video with 3D animations and the actual procedures which are being conducted inside the operation theaters, they are being merged, and the clips of those will be shown to the patient, and that will lead to more understanding of the patients regarding the intricacies of the procedure. And I think they are able to connect to the healthcare providers that what sort of complexity these procedures involve, and the possible complications they are able to understand more. So this, I think, video consenting and recording. I'm not sure about the recording, but video consenting is gaining popularity across the world instead of just written informed consent. So we are also being trying to move towards the video consent. But yes, coming back to your questions, the each and every patient here gets an informed consent, irrespective of his education level and irrespective of his social status.
Thank you, Dr. Pushkar, and putting onto a new light on video consenting. We'll come back to that question. Again, panelists, we are getting interesting questions in the chat. Please answer if you would like to, or if not, we could take it up in the question after the discussion. Next question would be like to Dr. Mayur. Dr. Mayur, the vulnerable category is those subjects who go for a clinical research, right? So would you like to take up and answer how well an ethical committee would in the hospital would take such decisions, and how the regulation aspects of it, sir? I would request
I think-
Dr. Kamal Patidar to mute. Team, please mute other than the panel members. Yes.
Okay, am I audible?
Yes, sir.
Yeah, okay. So regarding research and trials, the drugs are or the solutions are still under research, but we go through various stages of research, and once it is cleared for human trial, then only we are doing human trials. So that is one, and ethics committee makes sure that these clinical trials are run in an ethical manner, in a correct manner. So for that, yes, majority of the institutions, they have well-placed committees, and it happens in a systematic manner. However, still there will be a chance that it is possible that there are some loopholes. So these loopholes have to be closed by continuous evaluation of the process, and there might be some red flags also, where we need to see that basic human rights are not exploited, and basic is there any financial angle to it, is there any commercial angle to it. So these things we need to make sure, and I think then we are good to go. Another aspect is about privacy and confidentiality of the trials, and transparency of the information about the procedure or the medication which is being delivered. And one more aspect which I would like to say is that about the integrity of the whole process. Means the whole process should be it should have some integrity, it should have some transparency, and we should protect the basic human rights. We should protect the basic autonomy of the human being involved in the process. That is my stand on this. Did I answer your question?
Yes, sir.
Thank you.
Well
Thank
said. Thank you, Dr. Mayur. Next question I would like to take up for Dr. Nima. Dr. Nima, you said that yes, we have to involve children also in the decision-making process. But I would like to have your stand on the scenario where the child is not willing to take up the surgery or take up the procedure, and but the parents are doing, like they are when the two opposite poles in the decision, what would be your stand and your experience?
Right. So yeah, we have run into these conflicting situations where children, get sometimes very scared with the procedure that's being described, and they are not really willing to undergo it. But what ends up happening is when you have a detailed conversation with them, and you sit down and explain to them, and when you give them a little more time, what I do personally is I also encourage the family to have a separate discussion, and I speak separately to the patient as well. Usually, when we end up giving them a little bit more time, of course, in the situations that this is not an emergency, like we have at least 1 or 2 days to make this decision, and the parents have their own time to spend with them. We also have some, counselors, pediatric counselors, who are able to break down the concept of the children in the way that they can understand. Most often than not, I think in 95% of the situations, we are able to convince the child that this is the reason it is good for the child to undergo. And of course, with the family's agreement and their support, we are able to take the patient up for the surgery. In the very rare cases where we are not able to come to a consensus and the child is usually in the older age group and still not agreeable to the procedure, we sometimes even have halted it. Like I had a child, actually a teenager, who was about 17 years old, and he was diagnosed with lymphoma and had to undergo aggressive chemotherapy. After that, he actually relapsed with the lymphoma after about 1.5 years. He was in remission and then relapsed about 1.5 years later. Unfortunately, we had to take him up for a bone marrow transplant, so an autologous transplant. When we explained the entire process to him along with the family, bone marrow transplant is a very rigorous process. Patient has to stay in the hospital in one room for about 3.5 weeks, after which also they'll have to be, sort of in distance from their friends and school and all of that for at least about 6 to 9 months. And he was very vehement that he just did not want to undergo it. Then finally we had to give the choice to the parents and say, this is a situation, you have to now take a call, because he's absolutely against it. He's almost an adult at the age of 17, and you have to take a call. And they said, for now we would want to wait, we don't want to go with the procedure because it's a child's choice. Although he is he's 17, he's still not an adult, but he very well understands. This is after multiple sessions of meeting, convincing, consenting, or counseling and all of that, that he still did not want to undergo it. And given the gravity of the matter, like it was such a complicated procedure, it required a lot of effort from him personally as well as from the family. We sort of respected his wishes and decided to not undergo it. And he continued on chemotherapy, which he was okay with, and sort of did okay until maybe a couple years later, when he did not do so well. But I think everybody felt sort of content, or at least convinced in a way, that ethically, even though it was a child we were talking about, we had respected his wishes and we had taken his opinion into account and did everything according to him, and not forced him into undergoing something that we think is right for him, but he may not see it as fit for himself.
Okay, I think it's very tricky to take such decision to halt or to take continue with the treatment. I think it also depends upon the doctor's decision as well as the parents, right, ma'am?
Yes, but I think as doctors, you can't be the solo decision makers for
Yes.
patients. It's very important to involve the parents and the child. If they're very young, usually say around the age of 8, 9, under the age of 10, 12 years, and they really don't have a full 100% understanding, then we take the parents' decision. We've never, at least in my experience of last 10 years, I've never had to cancel treatment for a young child under the age of 10 years because a child said no and the parents said yes. And it ends up that the parents, talk to the family or the child and then convince the child to undergo the procedure. That has never happened. This is usually a challenge in most older patients that are almost close to adulthood, and they really put their foot down. And this happens more in the West, from my experience, than over here. Here, I don't know in what sense to take that. Is it good? Is it bad? To be honest, even I'm not sure. But the older children in the West are more outspoken, and they say, I really don't want to undergo this, and I want to lead my life right now in this way that I foresee. And we have to respect their wishes and say, okay, this is what you want. Sometimes it has happened where they've come back 1 or 2 years later and they said, now I'm ready for the procedure. If they've actually done well on chemotherapy and they'd not been ready for transplant, then maybe about 6 months, 8 months, 1 year later, they come back and say, yes, now I'm ready. I've given it thought. I have understanding of it. I'm ready for it. So I think a lot of patience and that comfort that you get with the patient and the family. And again, as I said, it comes with it takes a lot of effort from the doctor, as in it takes a lot of repeated number of meetings and counseling sessions. Our supportive healthcare workers also play a huge role. Like we have social workers, sometimes we have a adolescent counselor, we send them to a psychiatric counselor or a psychologist. So all these things come into play, and I think help them and us come into the right decision.
A great talk to you, ma'am, Dr. Nima. And this confusion was always there with me, that how people will take a decision on treating your children. I think you have cleared it out very well. Thank you so much. My next question is for Dr. Vikrant, Dr. Vikrant, I think this situation is commonly seen in critical care areas, where who will take actually the decision of the critically ill elderly patient. So when an age-old people come with a critical condition, who will actually take a decision on behalf of them? And I have seen many cases where people we talk that probably 2 days in hospital would have saved the patient not to discharge so much, or a discharge again medical advice. And do you think such decisions taken on behalf of someone is helping us out, especially when it comes to a parent making a decision for a parent? Over to you, Dr. Dr. Vikrant. Dr. Vikrant, are you able to hear me? Vikrant,
Can you hear me now?
Yes,
Yeah.
yes.
So I had muted myself. So it's a question which touches a very, very sensitive topic. The autonomy, or what you can say, India is lagging behind the West in this regard, I would say, to an extent, because in India, most of the decisions when the patient is critically ill are taken at the time of admission or after the admission.
Okay.
Most of the people, or many of the people, are not aware of the diseases, the eventualities, the emergencies, and they are not planned. They have not planned accordingly. In that situation, if I am in that situation, what decision I would take? If suppose, God forbid, if I undergo I face some accident, I get admitted to hospital, and if I am sick, what the doctors or the medical team should do? Whether they should treat me aggressively, whether if the life support is required, whether they should go ahead and do that, or I won't opt for life support, however sick I am. So these decisions are taken well in advance in West in many cases, but in India, we are lagging in this aspect. So most of the decisions in most of the cases are taken after the event has happened. Once the patient is admitted in the hospital or in the ICU, or is going for a operation theater, going to operation theater. So this is, I would not say this is the correct time to take decisions, especially in the cases of elderly people.
Okay.
When many of them might be having some disease or some difficult to treat disease. So yes, in if you consider Indian scenario, in our case here, in most of the cases, if the patient is not in full senses, as Dr. Pushkar said, that to give any consent or to choose or decide a plan, first of all you need to have your consciousness preserved. You should be in full senses. You should be in a situation with respect to age, understanding, that you can take a valid decision, right? So if it is there, then a patient, however elderly he or she can take a decision. But if the patient is not in a situation to take decision, is not in senses, or is ventilated already, or is sick, very very sick, not understanding what's happening, or due to some mental or psychological issue is not in senses. In that situation, the nearest family member, maybe spouse or a son, daughter, they can take decision. And generally, that's what happens in Indian scenario. The nearest family members, the spouse or the children, they take decision on behalf of the elderly person who is in the hospital or in the ICU, or is planned for a operation, emergency surgery. So in such a situation, we have observed that I mean, it many times it becomes difficult to understand the family dynamics, the patient's will. So when we talk to the family members of the patient, even though we stress upon that, what is the situation and what needs to be done with respect to the investigations and the management, what our further plan would be, we also take into consideration the family's opinion and patient's opinion when he was well. So many a times during family discussions, people discuss, if I get into hospital, please, don't put me on the in all the
Correct, correct.
distress and all the trauma of ICU, or ventilator, or big surgeries, those traumatic surgeries I don't want, and all those things. So you may not
Especially
have a living
catheters.
will, or you may not, yeah, so you may not have the legal wills for that, but you may discuss with your family member somewhere in your lifetime that I don't want that, I would not like to live a life that life that like that, and I would not like to be in the ICU for 2 months or 3 months, and I don't want to live in a vegetative state after that. So please don't put me in all those trauma. So many times patients relatives do tell us that, doctor, my father or my mother did not want the life supports kind of thing, and she did not want prolonged stay in the ICU. She did not want this big surgery. So please, we would like to choose this way, that we won't go for life support, and that's absolutely fine. See, it's a personal choice, and it is the choice of the individual whether to opt for that or not. But at the same time, what being a doctor, what being a medico needs to be done, it's our responsibility to put forward. Ultimately, what the patient himself or herself, or the family member on behalf of the patient, considering that it has been discussed in the family, whether to go this way or that way, whether to go in an aggressive way and do all the things which are necessary, like big surgeries, or the life supports, intubation, ventilation, dialysis, and invasive lines, blood pressure support, all those things, whether that is to be done or not done. So here, it involves a thorough discussion with the family members. We need to give them time. We need to involve them in the discussion and understand patients' will, and at the same time, all the dynamics the patient is going through, and based on that, we take decision whether to how to proceed in such a situation.
Thank you, Dr. Vikrant. I think wonderfully put down. And this actually laid base for my next question, which is on the living will, or an advanced medical directive, or passive euthanasia. Dr. Chaitanya, we would like to ask you a question. Though in 2018, Supreme Court has given permission for passive euthanasia, how well we have decoded it? Are we up for the living will? Over to you, ma'am. How is the practice?
Yeah, this calls for interesting discussion, Dr. Deepa. We spoke about informed consent as a patient right, and we also said that patient has a right to refuse treatment. Now, does this amounts to suicide? That is one way of looking at it. If a patient chooses not to continue treatment, the courts look at it as an offense as per Section 309 of the IPC, right? Which is punishable.
Yeah.
That is one aspect. But we all know that it is very clear that the patient has a right to refuse treatment. So this is the right which is given to a competent person. That is a person, a patient who is adult, conscious. We spoke about it, the capacity to give consent, 18-year-old, major, adult, who is out of free and voluntary will, without any force, with a sound mind, conscious, all of that. Now, if this provision is already there for a person who can give his consent, should the same, right be extended to a person who is not able, not competent to contract? In a scenario where the patient is sort of, in a terminal illness, irreversible coma, unconscious, he is not oriented. What does the law say? Can we sort of, is euthanasia legal in our country? Euthanasia means, literally means good death, is
Dignified death.
dignified death, right to die with dignity. Is it a part of right to life? Article 21, which we spoke?
Yeah.
Is the right to death with dignity, is it part of right to life? So these are various questions which have been posed from a long time, and we have seen again a lot of debates, discussions, the laws and regulations, all of it changing. I would like to take you to one case, in the 1996 Gyan Kaur versus State of Punjab, which was a 5-judge constitutional bench which overruled the certain earlier decisions, and it sort of said that Article 21, which means right to life, does not include the right to life or right to be killed. Okay, and 309, Section 309 IPC is not invalid; it is constitutionally very valid. The reason being, this constitutional bench said that the right to die is inconsistent with right to life, simply because death is inconsistent with life. So this is one historical thing. Now let's come to what happened with Aruna Shanbag case versus Union of India in 2011. We also know as medical professionals and healthcare providers, how Aruna Shanbag was practicing nurse in the KM hospital, Mumbai. So went into vegetative state after going through sexual assault, and there have been various writ petitions which have been filed. Unfortunately, passive anesthesia, though the medical board was constituted, but the medical board felt that she was sort of conscious and oriented, so withdrawing her medical treatment or the passive euthanasia was not sort of permitted. Of course, she died natural death. Now the question here again, right, is that is right to death with dignity, is it different from right to die an unnatural death? Yes. This is very, very clear. Therefore, that right to die, death with dignity, it does not amount to any other unnatural death like a suicide or culpable homicide and these things. So, though there were guidelines which laid down in the Aruna Shanbag case, the patient should have been diagnosed with persistent vegetative state for more than 6 months, rehabilitation more than 1 year. Then the family, the close of the kin can go to the High Court. You need to take sort of a permission from a 2-judge bench, and then the court will constitute a medical board, which will then again look into the ascertain whether the patient's condition is qualifies for removal or withdrawal of the life support. So that's how the cumbersome procedures were all laid down. But it was in 2018, the Common Cause versus Union of India, where there was clear-cut clarity as to when passive euthanasia is permitted, and when does what is the procedure to go about with the removal of life support and withdrawal of life support, and things like that. Of course, we all know active euthanasia, instilling a lethal medicine is illegal, but passive euthanasia has been provisioned for in these cases, and there are various procedures which have been laid down in this particular Common Cause versus Union of India. But if you again look at this particular, that's when the concept of advanced medical directive, commonly called as living will. I mean, but living will also has other meanings to it. But yes, advanced medical directive is again a right to every person. And it's an advanced exercise of, one's own autonomy, right? On what? On the level of care and the manner of care in the event I landing up in a situation of a terminal ill or an incurable disease condition, wherein I know I'm going to die. Yes, death is inevitable. And the machines, the equipments, of all of the drugs will only prolong the process of death, but I may not have a meaningful survival, because life is not just about existence or breathing. It means meaningful survival, right? So in that common cause, the procedure for the advanced medical directive is that, the executor, the person who wants to make an advanced medical directive for himself or herself, the document needs to be countersigned by the magistrate of first class, JF, MCVC, judicial first class magistrate. So and then the board gets constituted, and there should be two witnesses who are independent, preferably independent of the family. It should be countersigned, and all the approvals have to be taken through the court. And once such advanced medical directive is done, then the court has also a responsibility to keep copies of it, share it with the family, the names of people who are named in the advanced medical directive by the executor, also send copies to the local health authorities, to the municipal corporation, keep a set of digital records. So there was a lot of requirements. And also, how was it? That was about execution. Coming to implementation. So what happens if there is a patient in an ICU who is terminally ill, and and he has an advanced medical directive, and the treating doctor ascertains that I think this is the right situation where the AMD needs to be implemented. Again, the procedure laid down was that there should be a medical board which is constituted by the hospital, which consists of the treating doctor and certain experts with over 20 years of experience, 3 experts in super specialties, cardiology, neurology, and critical care, psychiatry likewise. And they give a preliminary opinion, which is given to the jurisdictional collector, and who then give it to the government medical board. And again, there is the second level, which is again a secondary medical board. So all of this, who again will give the opinion, which secondary medical board will have an representation from the chief district medical officer. So the process again in 2018 judgment was involved a lot of cumbersome procedures which involved the court. Actually, it was not very much practical for a person to go through in order to execute an AMD for himself or herself. That was it was considered very impractical. There was a lot of challenges. Of course, later in 2023, there has been an amendment to how one can get their AMDs done. So, like I said, initially, the document which has to be, which has 2 independent witnesses will continue, but the counter signature can go through a notary or a gazette officer. You need not go to the magistrate of the court. So there were some changes that were there, and the constitution of the board, the primary board, which gives the preliminary opinion, and the secondary board, constitution of 2 levels of board, again, his sort of, goes to the hospital where the patient is admitted. Of course, the secondary board will have a representation from the, the district chief health authority into it, where they opine. And of course, all this procedure involves educating the family members, taking their consent, and then finally it sort of, we sort of, take the procedure at the final stage, it goes to the permission of the court. So therefore, there have been a lot of changes in execution and implementation of AMD. Now, you spoke about, has it been decoded enough and all of things? It's still in the learning phase. Several states, are still in the process of constituting an appropriate authority. Who is that? The representation from the government into the secondary medical board of that hospital, who is going to give the opinion. So there are a lot of these things, but yes, many states have sort of, implemented this as well in terms of and a lot of people who are executing AMDs for themselves. But yes, very clearly now, right to die with dignity is considered part of, but of course it has certain inherent safeguards. So that's where the collective responsibility, though there is a prior consent and advance consent, but again, it's a collective responsibility so that there is no misuse, there's no exploitation, there's no abuse. So therefore, the treating doctor, the medical boards, the government machinery, the family members, and also the courts are all involved in sort of, I think this is going to take some time. But yes, this has been again a landmark change, a breakthrough in the way our country is looking at.
Okay, thank you, Dr. Chaitanya. Wonderful listening to you and major inputs about the Advanced Medical Directive. So thank you so much. And there are interesting questions coming up in the chat. Probably some of you have answered in between. Participants, you can put down your questions, and I would like you to give your feedback on the session, and any other topics you would like us to know. Please let us know. The feedback is put in the chat. Please give us a feedback. Ma'am, Chaitanya ma'am, there is a question for you. It says that, can you tell the state policy 38 and 62 and Ayushman Bharat, does Ayushman Bharat comes under this?
Please repeat. Can you repeat this question?
Ma'am, it's in short, it says that whether Ayushman Bharat comes under the directive DS Karnataka policy.
So if you, like I mentioned earlier, there are various directive principles of state policy, which has from the Constitution, which is giving directions to the state, trying to say that it's your obligation to maintain public health, right? So if you have seen for a long time now, the governments, various governments in various forms, have been trying to provide for universal health coverage, right? Whether it is immunization or the primary care, secondary care, and a lot of things, with lot of programs, the Jan Arogya schemes, Ayushman Bharat, then you also have, Ayushman Bharat digital mission,
Yeah.
The various programs which actually are, the states have demonstrated implementing the directive principles of state policy, and also ensuring that health is sort of, right to health, which is obligation, which is their duty, is being followed. I think the government has taken a lot of steps. Now, why DPSP is not enforceable, when it sort of, was constituted, is because if you see in the fundamental right, like I have a right to, life, or right to freedom of speech and expression, or freedom of press. But yes, the explicitly being mentioned under, Articles 14 to 32 may not capture right to health directly, but Article 21 and the DPSPs have been implemented, and Ayushman Bharat is definitely a demonstration of giving the access, making available resources available for one's health, for public health, and also looking into the affordable and, affordable care initiatives, and, those kinds of things.
Yeah. Ma'am, this question, I think, for all of us, which Raja Lakshmi has put one interesting question. Though she has put about the video consulting, where Dr. Pushkar said that we can put a 3D diagram on what the procedure and show it to the patient. So, and even in the verbal or the written consent also, when we are saying about the complexity of the procedures, people may get anxiety, right? So, for open-minded people or who are relaxed, this kind of information is good. But what if the patient is already anxious about his, and that may lead to some other complications? So I think any one panel member can answer. Dr. Mayur, if you would like to answer this.
Yeah, I would like to answer this
Yeah.
question because, see, as a neurosurgeon, you know that I operate on complex brain tumors, spine conditions, and so on and so forth. So every neurosurgical procedure has potential complications, which includes neurological deficits, coma, or even death. So it is integral for me to counsel each and every patient about these heavy potential complications. And how we put across, that is very, very important. And in that process, videos are very useful. If suppose patient is anxious, just now recently I did one huge tumor, like 8 centimeter size tumor inside the brain, and patient had already had paralysis and she was 70 years old. Then what I do is that I make everybody sit together. I explain them this is the situation. I show them the tumor in the MRI. And then at the same time, I tell, if you are willing, I will show you the video of previous similar patient who has improved after surgery. So you
Okay.
expose what kind of video you are, you expose them, which video you should be exposing. You should see, okay, you show them a patient who has already undergone a craniotomy, which is less threatening, and a patient who is walking after surgery. And in that I will be conversing with the patient and I will be asking, ಎಷ್ಟು ದಿನ ಅయింದಿ ಅಮ್ಮ ಆಪರೇಷನ್ ತರುవాత, means after how many days your surgery you are walking. Then they will tell, sir, this is the third day of surgery and I am walking. And then there will be a smile on their face, and there will be smile on the family member's face. That starts cooling down the anxiety.
Okay.
And that is how you bring next topic. Okay, now would you like to see a video of craniotomy being done? Then they will tell, yeah, if this patient's video only I can see, great. Then I will, that is where my directory of videos will be useful. And slowly we can put some more concepts, and then we can tell, see, then any surgery, it has chances of infection, bleeding, complications and all. Then it becomes easier. And then what I mean to say here is that we have to reorder the things.
Okay.
Like children, no, if we are taking care of children, we should know how to take care of children. Same way, patients are like our children, our family members. We should know their psyche. We should know that, okay, this is where they are able to digest this much of information. And then from that digestibility, you expand onto their appetite and information, like that.
Thank you, Dr. Mayur. I think wonderfully put down.
I would like to add,
Yes,
few points here.
Yes, sir.
So the very question, has got a different aspect. I think so, because as the questions suggested, that what if she gets into anxiety and that leads to
Correct.
further complication, that is going against the very principle of informed consent, ma'am. So the
I agree
informed
to that.
consent is meant to understand the complications. And nobody, while giving the consent, can shy away or can hide away from the complications, the intricacies of the procedure or the surgery. However, worse or bad they are, we have to talk to the patient and the patient's family members. We have to let them know, yes, this can happen, even though the complications are rare. In many procedures, they are rare. And, approximately these many percentage of people may have, but yes, they can happen. And that we should know, you should be aware of. Hiding this information goes against the principle of informed consent, or not discussing this information with the patient and the family members goes against the principle of informed consent. So I think the question itself, goes against the very principle, and we should make an effort, being the medical fraternity, that
Right.
everything, including the benefits and the kind of procedure, the way it will be performed, under which anesthesia it will be performed, and what are the possible complications, and how, if the complication happens, how we can treat that. Everything should be discussed with the family members without any hesitation, and without the other thoughts that patient may slip into further anxiety, depression, and no, that these are totally different aspects, ma'am.
Very nice,
They
very
will be
nice.
taken care in a different way.
Yes,
But
I agree to
the focus
Dr.
should be on the procedure.
Very
Yeah,
nice.
I agree to Dr.
Right.
Vikrant, but I also agree to Dr.
I
Mayur
have,
in which
No, no,
order we have to say that
yes,
about
yes.
it.
yeah, agreed.
Deepashri ji,
Absolutely.
I would like to
Order
say
should be
Vikrant is
followed.
absolutely right here. The thing is that if it is patient's right to know the things, it is doctor's responsibility also to tell all the things.
And furthermore, I want to add one point here. Is informed consent is not only a responsibility of the doctor. It is a three-pronged responsibility. The responsibility lies with the doctor, number one. Number two, it lies with the hospital. And number 3, it lies with the consenting patient or the family member. I will explain how. So as doctor's responsibility, we have thoroughly discussed, and most of us are aware that it should be thoroughly discussed, informed, the doubts should be cleared by the doctor, whatever doubts the patient or the family members has. The responsibility of the hospital is they should cooperate with the doctor, if whatever new ideas the doctor or the team has to, ease this process. Like Dr. Pushkar suggested that video consenting is going on. I had visited a hospital in US last year. They have pamphlets, they have booklets of, a particular disease or a particular procedure patient is undergoing, and all the information for that particular surgery is printed in that, including the ways, including the alternatives, including the kind of anesthesia it is done in, including the possible complications. Every information is there in that booklet. So there is a library in that hospital where all the kinds of, including ALL, AML, what kind of chemotherapies are available, what are the complications of the chemotherapies, all the booklets are available. A patient's family member, not patient, patient's family member can go over there, can, choose a booklet, can take n number of booklets with him or her, to study, and get accustomed with the procedure. See, every time the informed consent may not be an emergency one. Every time patient may not be in the ICU or emergency OT. There you may get time to consider about a surgery, whether to go ahead or not go ahead. It might be an elective surgery. So patient or patient's family member. So I will come to the third point, how it is a responsibility of patient and patient's family member also, that it's not a enforced decision. Okay, so you should take time, you should consider all the pros and cons of the surgery, you should consider what is good for you, and what doubts you have, you should clarify with the doctor without any hesitation. You should ask all the queries with the doctor, and if the doctor refuses to answer, then definitely you can consider opinion of another doctor. Okay, so it's the responsibility of the patient and patient's family member to get clarified with all the doubts before giving the consent and going ahead for a particular operational surgery.
Yeah, thank you so much, Vikrant, making it a statement that it's responsibility for both doctors, healthcare providers, as well as a patient to give a consent and to take a consent by a doctor. Thank you so much. And I know I have exceeded 37 minutes as scheduled, but this discussion is very much interesting, and I think it will keep on going because health is definitely an important issue for all of us. There are a few questions. Probably we'll send it to each of the speakers related topics, and you can respond and we can send it to the participants. And thank you, participants, for your wonderful time. And please enable videos if possible. We would like to take a great gather on this World Health Day and remember it forever. Please enable your videos so that we can take a group photo. Meanwhile, we will be reposting our feedback link. Please ensure you give us feedback, and this will help us to organize such wonderful sessions again and again. Please enable your videos. I'm requesting all of the participants to enable their videos. We can have a photo together. Yeah. Requesting Lambodar to take a screenshot. Yes, this is also your right. So taking it as in consent, if you're okay, please enable your videos. Yes. Hope Lambodar,
You are taking video consent.
Yeah, video consent. Yes, sir. Applying it now. Yes. Okay. Lambodar, hope you have taken few photos.
Yes.
Yeah. Thank you so much. It was wonderful day, wonderful start a new year with the World Health Day, and happy Ugadi to all of you. Thank you, Pushkar sir, for joining us. And thank you all the panelists for joining us.
Thank you.
Thank you very much for inviting and giving an opportunity.
Thank you.
Thank you, sir.
Thank you.